Hello all, welcome to Physio TV. On the occasion of World Arthritis Day 2022, we have Dr. Priyanka Panchal to give her insights on exercise prescription for older adults with knee osteoarthritis. Dr. Panchal is a musculoskeletal physiotherapist, certified Mulligan therapist, and a credentialed McKenzie therapist. She did her bachelor's from Government Physiotherapy College and Spine Institute, Civil Hospital, PGMC campus, Ahmedabad, Gujarat, and her master's from Sancheti Institute College of Physiotherapy, Pune. Ma'am has more than a decade of clinical experience now, and she runs her own clinical practice in a specialized orthopedic physiotherapy clinic in Vapi. Over to you, ma'am.
Thank you so much, Nikita, for a sweet introduction. So I'll start my screen sharing and we'll begin with the presentation. A warm welcome to everyone who will be hearing this presentation. So as already mentioned by Dr. Nikita, the presentation topic is exercise prescription for older adults with knee osteoarthritis. So osteoarthritis is the most common form of arthritis till date, and it affects women more than men. It affects multiple joints of the body, sometimes causing polyarthritis as well. But the most common joints which are affected are the knee joints, followed by the hip joints, the spine, as well as small joints of the hands and the great toe of the foot. It is one of the leading causes of disability after diabetes and dementia. And the prevalence of knee osteoarthritis has been reported to increase with every decade of life, with the annual incidence of knee osteoarthritis highest in the age group of 55 to 64 years. And also it has been reported that at least 1 in 3 individuals above the age of 65 years are affected with arthritis. The prevalence is further expected to increase substantially in the coming decades due to a rise in the risk factors associated with it and an increase in the aging population. The Osteoarthritis Research Society International defines it as a disorder involving movable joints characterized by cell stress and extracellular matrix degradation initiated by micro and macro injury that activates maladaptive repair responses, including pro-inflammatory pathways of innate immunity. The disease first manifests itself as a molecular derangement, meaning an abnormal joint tissue metabolism, which is followed by anatomic and/or physiologic derangements, which is characterized by cartilage degradation, bone remodeling, osteophyte formation, joint inflammation, and loss of normal joint function, which can all culminate in an illness. Now, the most recent research says that apart from the injury-induced inflammation and the age-associated inflammation, which is also called as inflammaging, the presence of low-grade systemic inflammation due to certain other risk factors like obesity and other metabolic syndromes is also responsible for triggering the osteoarthritis. So basically, osteoarthritis is something which affects whole of a joint. It affects the cartilage, the meniscal tissue of the knee joint over here in this example. It affects the synovial joints, the synovium of the joint, also the bony surface, and sometimes also affects the ligament of the joint, right? So all of this causes pain, and because of which there is functional limitations, poor sleep, fatigue, depressed mood, and loss of independence of the patient who is affected. So we'll have a look at the risk factors. Osteoarthritis can be triggered in someone who is increasing in age, may already have genetics which are prone to getting which are prone for someone to have osteoarthritis. Even the joint structure or alignment, the occupational loads, obesity, physical inactivity, and history of joint injury are responsible for triggering osteoarthritis. Now, out of this, physical inactivity is further associated with muscular weakness, which is also one of the risk factors. And out of all these risk factors, we can modify to some extent, to a larger extent rather, obesity and physical inactivity are the ones which can be modified and worked upon so that the effects of osteoarthritis due to these factors can be reduced on a larger scale. The rest of the risk factors are non-modifiable, yes, but to some extent occupational loads also can be modified, but not always. Going ahead, there are comorbidities which is present in a patient or an individual who is going to come with osteoarthritis of the knee joint. So someone presenting to you in your clinic with a knee osteoarthritis is not always going to present with one condition itself, but might have several other comorbidities like cardiovascular disease, diabetes, hypertension, dyslipidemia, and obesity. And it's been estimated that 59% to 87% of people with osteoarthritis have at least one other chronic condition. So as I already mentioned, someone presenting in your clinic with knee osteoarthritis is going to have one or the other of these comorbidities already with them. We'll have a look at the relationship between osteoarthritis and these comorbidities. So first of all, if someone with obesity and knee osteoarthritis is presenting, then because of the pain and difficulty in walking due to the osteoarthritis, it will make it very difficult for the individual to lose their weight because of the obesity present already. Also, because of the impaired ability to walk, it also significantly increases the risk of cardiovascular events in these individuals because of more of a physical inactivity due to impaired ability to walk, and hence the risk for cardiovascular events is present. And also, if someone already has diabetes, then the inability of walking is going to predict a higher risk of serious diabetes complications. And if also someone is not having diabetes, there are chances that they will present with certain incidence diabetes because of the inability to walk. Now, we can see from this example in this one study, it was the predicted probability of difficulty in walking for a 60-year-old middle income normal weight women was seen, and it was found that if this population is having no health problems, then there will be a 10% difficulty in walking. If this population is present with diabetes and heart disease, then there is at least 20% of difficulty in walking. And if this kind of population is affected with at least bilateral hips or knee OA, then there is a probability of 40% difficulty in walking, and there is a 70% difficulty in walking probability because of presence of diabetes, heart disease, and bilateral hips or knee osteoarthritis. So this shows that the overall burden of combined effects of the risk factors, the comorbidities, and the disease itself is very high on the quality of life of the individual who is suffering. Okay, so why is this such a problem and such a huge issue? Because because osteoarthritis is something which can be cured with exercises, which can be managed, rather not cured but managed well with exercises. So the problem lies where is that osteoarthritis of the knee is inadequately treated, especially in people with other chronic conditions. And the reason for this is, first, due to poor exercise prescription. So very few times it happens that overloading is done on the joint affected, meaning that a lot of exercises which triggers more of pain and swelling is given to the patient. This happens very rarely, but very commonly underloading of the exercises happens, meaning that people who are osteoarthritic are not given exercises which are challenging enough to facilitate a training effect. The second reason being poor patient adherence, and the reason behind this is because of the lack of appropriate education about the condition, because they have certain beliefs and in the myths and misconceptions about the condition, and due to lack of lack of knowledge of the expected outcomes, and also due to lack of optimal positive gains due to inadequate exercise prescription. So both these factors are responsible for poor outcomes because of the exercises in this population. And so for example, an individual with knee osteoarthritis manages by avoiding physical activities like walking that exacerbate his or her pain and end up with increasing the risk of other factors that could also trigger the progression of the disease as a result of inadequate treatment. And this is concerning because we know that physical activity, exercise, diet, as well as lifestyle modification are the most effective and safe non-surgical and non-pharmacological management options for these individuals, right? So, and also there have been so many evidences in the form of so many randomized controlled trials that have shown that physical activity, exercise is effective in reducing knee pain, improving function, and preventing development of major mobility limitations compared with the usual care that we provide. And it has also been shown to reduce excess body weight and thus reduce the joint load, the joint stiffness, muscular weakness, depressed mood, and poor balance, and has positive effects on lipid metabolism, hyperglycemia, and systemic inflammation. So all of these is definitely going to also positively affect the patient's quality of life. And also the recent treatment guidelines provided by the Osteoarthritis Research Society International in 2019 also recommends that the arthritis education, structured land-based exercise programs, including strengthening exercises, cardio exercises, balance and neuromuscular exercises, and even Tai Chi or yoga, which can be included in neuromuscular type of exercises, are the core treatments recommended by the OARSI. Apart from these, certain other exercise and other alternative treatments like aquatic exercises and gait aids, self-management programs are also helpful, but are conditionally recommended. The core exercise prescription or the core exercise treatment guidelines are the ones mentioned earlier. So we know we have all these evidences present. And so the solution to the problem of poor exercise prescription and poor patient adherence is the need for adequate exercise prescription and patient education. Now for that, to begin with an exercise prescription, we need to screen the patient with osteoarthritis of the knee for their comorbidities and risk factors which can be involved. And that can be done with a thorough history taking of the patient, which is going to include the patient information like their age, gender, occupation, just to know about the mechanical stresses that they are having currently, their leisure activities, if any, and any kind of functional limitations or any kind of limitations in their social environment or their social environment as such, we can understand from this part of the history. Apart from this, history of the present condition, which is very important. We need to understand their pain location, the onset of their pain, which was like maybe acute, subacute, or chronic. The causative factor, sometimes, as we already know, that osteoarthritis can be caused as a result of an injury, past injury or post-surgery, which has affected the joint, or it can also be because of the certain other risk factors. So we need to understand the causative, the probable causative factor over here, and the status of the condition, whether it is improving, whether it is the same, or whether it is worsening day by day. And in detail, understanding of the aggravating and relieving factors is going to help the therapist in designing the exercises for the patient and choosing the best exercise for the patient. The nature of the symptoms, pattern of the symptoms, whether there is an intermittent or constant type of pain which is present in these patients. And also it is important to take the subjective, the pain rating of these patients, and understand the sleep disturbance pattern, which is also going to give an insight on how much it has affected the mood or the quality of life of the individual. Apart from these, the patient who might present to us might have already undergone some kind of treatment for their current condition if it is chronic. So we need to have an understanding of their prior conservative treatments, if they have done their effectiveness, and also any kind of alternative therapies or any kind of alternative medications like Ayurvedic treatment or homeopathic treatment or any kind of home-based remedies if they are doing already. And also the most important one, the medical history, is here a crucial role for the clinician to understand if there is any kind of red flag indications for which we need to refer the patient right away to another healthcare profession to understand in detail about the comorbid conditions, if any. So we know that commonly these kind of patients, commonly the patients with knee osteoarthritis might present with obesity, might present with diabetes, hypertension, dyslipidemia. So we need to take a detailed history of how long they have been facing these problems and how they are tackling with medications and so on. And also to understand if they have had any kind of major illness which is relevant to the current condition. So apart from all these things, the imaging reports, usually the patients get them with them. The X-ray is commonly done, and the laboratory tests for the comorbid conditions if they have regularly been following up with that. And yes, the most important part of the history is to understand the specific goals of the patients. If they have any kind of expectations from the therapist, any particular goal. For example, if someone is obese or overweight and is having knee osteoarthritis, they might want to reduce their weight. So that will be their goal. So this kind of detailed history is going to help the clinician in order to design the exercises, as well as in order to conduct the physical examination as well. So the physical examination is going to include a detailed evaluation of the joint itself, which is affected, for the range of motion, both active as well as passive. The muscle strength testing probably can be done by manual muscle testing, or for the purpose of exercise prescription can use the 1RM checking method as well. We need to have a look at their joint alignment, any deformities if present, any edema if present in the feet or in the knees affected as well. Now, if there is an indication, we also can do a neurological evaluation, which will include the reflex testing, dermatomes, myotomes as well, because not everyone is going to present just with knee osteoarthritis and certain other comorbidities, but they can also have some kind of neurological problem as well. So this is going to give a lot of insight about the patient's condition. And then we begin with the proper physical examination in order to design the exercise prescription. So for that, we need to take into consideration the BMI of the patient. So you check the weight, their height, calculate the BMI, and find out if they are overweight or obese or not. And also we take the detailed balance and functional mobility exams of these patients. We check their gait pattern with or without the footwear. If they are using any kind of assistive devices, like say for example, they are using a stick to walk or they are wearing kneecaps. So we need to check with and without that how they are behaving while walking, and what are their beliefs regarding these devices, as well as what are their concerns about their walking pattern. And apart from these, certain functional mobility tests like the 30-second chair stand test, stair climb test, timed up and go test, and 40 meters fast-paced walk test. All these are recommended by the OARSI to be done wherever and whenever it is applicable for that particular patient's condition. Okay, and yeah, so these are going to give a baseline for the clinician to compare with the pre and post exercise situation. 6-minute walk test is also recommended by OARSI in order to be done to test the endurance or cardiorespiratory function of the patient. And apart from that, clinical graded exercise testing is also one of the options in order to check the aerobic capacity of the individuals. Now, the whole of the history and a part of the physical examination is going to help the clinician to make a decision, or rather to find out whether the patient can be classified into high risk, moderate risk, or low risk. Now, how to do that? So from here we can understand that the clinical presentation of high risk patients is someone who is going to have certain signs and symptoms like pain, discomfort in the chest, neck, arm, jaws, which is going to indicate some kind of cardiovascular problem. Apart from that, dizziness or syncope, if they are presenting with shortness of breath at rest or with exertion, ankle edema, palpitations or tachycardia if present, any intermittent claudication, known heart murmur, unusual fatigue or shortness of breath with usual activities, and orthopnea or paroxysmal nocturnal dyspnea. So all these kind of signs and symptoms we need to look for, because this will classify the patients into high risk category. Also, someone with cardiovascular disease, renal disease, or are symptomatic or diagnosed with pulmonary disease, including COPD, asthma, ILD, and cystic fibrosis. Apart from these diseases, people who are diabetic and at least are above age of 60, about the age of 35 years, have diabetes type 2 for more than 10 years, have type 1 diabetes for more than 15 years, or are having hypercholesterolemia, that is a total cholesterol more than equal to 240 milligram per liter, or hypertension, where systolic blood pressure is more than equal to 140 and diastolic more than equal to 90 mmHg, or if they have a history of smoking or a family history of CAD in the first degree relative less than 60 years, or a presence of microvascular disease or peripheral artery disease or autonomic neuropathy. All these conditions, if these are pre-existing in a patient, is also going to make them fall into the high risk category. So for that reason, detailed medical history of the patient is important. Now, the listed risk factors in this table: the age, family history, cigarette smoking, sedentary lifestyle, obesity, hypertension, dyslipidemia, and prediabetes. These are the risk factors where if less than 2 of these risk factors are present, the patient can be categorized into low risk. And if more than equal to 2 risk factors are out of all these are present, then can be categorized into moderate risk factors. Now you can have a detailed look of all these tables in the ACSM books and have a clear understanding of all these risk factors and factors which can affect the individual. And because this is going to be one of the important factors for designing the exercise prescription, it is important to know all these factors in some detail. So when the clinician has classified the patient into a low risk, moderate risk, or a high risk condition, then it is important to understand, in order to prescribe the exercise, whether all these patients would require a medical exam, an exercise, a graded clinical exercise test, or an MD supervision of the exercise test, whether it will be required or not. So from here we can see that someone falling into low risk and moderate risk is not going to require any kind of a detailed medical examination or a graded exercise test, and an MD supervision for the exercise test is not required if you want to prescribe light, moderate, and vigorous exercises for these individuals. Yes, to prescribe vigorous intensity exercise for moderate risk patients, you would require a medical exam done, that is the a clearance from the MD that they are fit to go for a vigorous intensity exercise, but not always an exercise test is recommended. So the most important part where clinical exercise testing should be done, the medical exam should be done under MD supervision should be done, is the high risk population. Those who already have an ongoing cardiovascular, pulmonary, or renal or any metabolic diseases, or who have certain signs and symptoms that we already saw in the tables previously. For them, it is recommended that a medical exam should be done, the exercise testing should be done, and MD supervision for submaximal or maximal exercise testing can be done. Now over here, for prescribing light exercises, light intensity exercises, for someone who is just diabetic and osteoarthritis, they may not require an exercise test. But someone with more than that, more than diabetes as well as osteoarthritis and other comorbidities, out of all these, someone with diabetes has chances of more added risk for cardiovascular conditions. So if you find that they are actually into high risk condition, then an exercise testing should be done, and this should be done by someone who is trained in doing clinical exercise testing, or under the physician supervision. So yes, so we have seen already that though exercise testing before initiating a physical activity is not routinely recommended, except for the high risk individuals, the information gathered from the exercise test may be useful in establishing a safe and effective exercise prescription for lower risk and moderate risk individuals as well. So you can choose to do the exercise testing. Maybe you will not require an MD supervision for such patient population who fall into the lower risk and moderate risk. So for these individuals, symptom limited submaximal exercise testing can be considered. And if you feel, or if you find that it is inappropriate or inadequate for these patients to perform even a submaximal test, then in that case, functional mobility and endurance tests should be considered. Now we have a little more understanding of certain special considerations for knee osteoarthritis individuals for exercise testing. So exercise testing, first of all, is contraindicated in patients who are having an acute inflammation. So the exercise testing can be postponed until the flare has subsided. Secondly, the use of the mode of testing. So the use of cycle ergometry alone or in combination with arm ergometry may be better tolerated by people with knee osteoarthritis, although some individuals do tolerate treadmill walking as well. So it is on you as a clinician and the patient's presentation to select the mode of exercise testing. And also it should be the least painful for the individual. Thirdly, you have to allow ample amount of warm-up, at least 5 to 10 minutes of warm-up at a light intensity where you can include certain light range of motion exercises or maybe simple normal paced walking for 5 to 10 minutes for these individuals before you begin the graded exercise test. And you need to monitor the pain levels throughout the test, and you need to terminate the test if the pain is too severe, apart from taking into consideration the other termination criteria for a graded exercise test. So from here we can see that the purpose of submaximal graded exercise test for knee osteoarthritis individuals is to determine the heart rate response to one or more submaximal work rates and use it to predict the VO2 max, which is going to give us an idea about their aerobic capacity. It can, the purpose of the submaximal test is to test the cardiorespiratory fitness or aerobic capacity, which can be calculated from the VO2 max that we get, and to obtain or establish a baseline that can be used to track relative progress. So yes, if you decide to do a submaximal test, it is going to help in one or three of these methods. You can have a baseline for your patient set, because every time it is not possible to compare your findings with the normal values. So in that case, you can have a baseline for your individual patient, because it is going to be very patient centered, and then you just compare with their pre and post exercise situation. Okay, so as already mentioned, the least painful type of mode of exercise has to be chosen, like the cycle ergometry, arm ergometry, and treadmill. And the example of cycle ergometry submaximal graded exercise test is the YMCA protocol. So the details of these you can find in the ACSM book, where they mention that you increase the work rates in certain time frames, and where you have to track their heart rate response and also check the rate of perceived exertion, their blood pressure, where you will be guided in order to decide whether to terminate the testing or to continue with it. And at least from that, all that data, you can extract the heart rate response, you can calculate the VO2 max, and also understand the baseline of the patient. Okay, and so the benefit of submaximal exercise testing is to provide a general reflection of an individual's physical fitness, right? So you understand where they fit into the aerobic capacity normal values and this all can be done at a lower cost, potentially reduce the risk for adverse events, and requires less time and effort on the part of the subject. So here we begin with the exercise prescription part. So when you have found all the data which is going to help you with exercise prescription, then you will be good to go for prescribing the exercises like aerobic exercises for these individuals. So the recommendations provided by ACSM for aerobic exercises is at least 3 to 5 days per week of aerobic exercise, the intensity of which has not been determined till date, though it has been seen based on several studies and several researches that a light to moderate intensity, that is 40 to less than 60% of heart rate reserve physical activities are recommended, because these are associated with lower risk of injury or the pain exacerbation. So you don't want that your exercise will overload the patient, right? And also very light intensity physical activities which is 30 to less than 40% of heart rate reserve, are recommended for individuals who are deconditioned, or say they are doing the exercises for the first time in their life after so many years. So this type of frequency and intensity of aerobic exercise is recommended for at least 150 minutes per week, which can be broken down into 10 minutes of short exercise, short bouts of exercises, which can be progressed over a period of time, so that you achieve at least 20 to 60 minutes per day of aerobic exercises. The type of exercises that you choose for aerobic has to be of low joint stress activities, like simply walking, or say static cycling, swimming, or aquatic exercises. Now here, the most feasible ones for the Indian population is walking and cycling. Apart from that, if the patient can afford swimming or aquatic exercises, or if you feel that it is feasible for them, helpful for them, then aerobic exercises like swimming and aquatic ones can also be chosen. The progression of aerobic exercise should be gradual and individualized, which is based on their pain and other symptoms. Okay, so as I already mentioned, that we can increase the time of aerobic exercise from 10 to 20 to 30 to 60 per day, and that is how the progression would be happening. So many RCTs have done studies on the benefits of aerobic exercises for these populations, and the benefits mentioned over here are clubbed from all those studies. So what they have seen is that aerobic exercise reduces pain, stiffness, joint tenderness. It also improves the physical function, that is the aerobic capacity itself. Certain functional mobility tests, the timed chair test, 6-minute walk test, and self-rated ADL performances will also be improved. It does not cause a disease progression, and this is very important because most of the patients have a mindset or a belief that if they exercise, like if they walk more, they are going to progress their disease. It improves their quality of life as well. So as a clinician, we need to know the benefits of these exercises and also to address these as an education to the patient. The second recommended exercises by the ACSM is the resistance exercises. So at least 2 to 3 days per week of resistance exercise with a rest period of more than equal to 48 hours between a single muscle group is recommended, with an intensity which is appropriate, and it hasn't been determined very finely by the ACSM, but it has been seen that light and higher intensity resistance training both have shown improvements in OA individuals. So it is very individualized. You have to decide whether you want to choose the light intensity or the higher intensity. And based on most studies, it has been seen and recommended that light to moderate intensity of resistance training, where higher number of repetitions at a lower percentage of repetition maximum, which is 40 to 60% of 1 RM, can be used for these individuals. The time duration is not very specific, and the time spent in resistance exercises, its effectiveness has not been studied or identified. But the type of exercise that you choose for resistance exercise can be the strength, endurance, and isometric muscle training, where you have to include major muscle groups for these individuals. So for someone with knee osteoarthritis, you need to focus on the lower limb muscles from hip, knee, and ankle. So you work on all those muscles, where you can include multi-joint or single joint exercises, use body weight equipments, anything which and everything is recommended. Now, for example, say if you want to work on the strength of the patient, then you can start with 10 to 15 repetitions, and if you want to work on the muscular endurance, then you begin with 15 to 20 repetitions, where you also can have a range for the sets of the repetitions which you provide. So 2 to 4 sets to improve the muscle strength, single set in older individuals who are newbies, and less than 2 sets are effective for improving the overall strength. All right. So resistance exercise, how to progress with that? Gradual and individualized is what is recommended by ACSM. But commonly, if you want to, commonly we have seen that we progress by increasing the resistance, and you keep the number of sets the same. Okay, but also you can work on increasing more number of repetitions per set, and also the frequency that can also be chosen. So you have to be innovative, and you have to be very subjective in deciding, as well as taking into consideration the patient's situation and their symptom limitations in order to prescribe resistance exercise. So also based on many studies, the benefits of resistance exercise has been seen to improve pain, stiffness, quality of life, self-efficacy, depression, strength outcomes, range of motion outcomes, walking endurance, walk time and speed, stair climb and sit to stand ability, timed up and go, reduced fall risk, improved bone density, improved energy metabolism, reduced cardiovascular disease risk, and increased insulin uptake. So all these benefits are not only going to affect the knee osteoarthritis itself, but also these studies show that they are affecting the other comorbidities and other risk factors which have been involved in the patient's condition. So now we move on to seeing the third recommendation by ACSM, which is the flexibility or range of motion exercises. So these are recommended daily, and the intensity of the stretch is to the point of feeling tightness or slight discomfort for that muscle tendon group. The time recommended for stretching is 10 to 30 seconds for most adults, or even 30 to 60 seconds for older adults, which may confer greater benefit in these population. The volume of flexibility exercise, it should be seen that at least you have to perform a 60-second of total stretching time for these people. And the type of flexibility exercise can be static, it can be active or passive, dynamic. All are seen to have effectiveness on the individual's flexibility and range of motion, and it should include all the major muscle groups of the knee. The progression is again gradual and individualized based on the individual's pain and other symptoms. The benefits of flexibility exercise is to maintain the range of motion of the joint, and also the flexibility of the muscle tendon unit. Now, apart from aerobic exercises, resistance training, and flexibility exercises, as we have already seen in the treatment guidelines provided by OARSI, we have seen that balance and neuromuscular exercises are also recommended. So over here, there is not much of study which is done on this particular type of exercises for knee OA population. But it has, based on the limited data which is available, it has been recommended that 2 to 5 days a week of balance training or neuromuscular control training with a duration of 20 to 30 minutes is enough for training these individuals with this type of exercise. So the intensity is not clearly determined, but it should be challenging in order to make improvements. For example, the exercises which are included in these category can be Tai Chi, motor control training, and static or dynamic balance training exercises. Now, it has been seen the benefits of these exercises. It helps improve the balance, agility, muscle strength, and reduces the risk and falls and fear of falling. So yes, you can choose whether you want to include this type of exercise training for your patient or not based on the functional mobility and balance testing that you do in the physical examination. Now, apart from all these, as an individual exercises, multimodal exercises like a combination of cardiovascular and resistance, cardiovascular and balance, resistance and balance, or cardiovascular resistance and balance, all of these in certain combinations can be used, which will obviously depend on the goals of the individual. So there are certain special considerations for exercise prescription while the patient is going to start with the exercises which you need to take care of is to avoid strenuous exercises during flare-ups, to use adequate warm-up and cool-down periods. So 5 to 10 minutes of warm-up and cool-down is recommended, where you can use simple range of motion exercises or simple walking for the patient. Set achievable goals for individuals with significant pain and functional limitations. Inform or educate the individual about the associated discomfort or new pains during the exercise. So, for example, soreness is very common when you begin with any kind of exercises for the first time. So, you need to educate them regarding this so that they are prepared and are also able to cope with this. Second consideration is that to advise to exercise when the pain is least during the day, because you're going to put them on an exercise prescription. Like say, for example, you need to walk 3 times a day. So they are going to walk on their own at a preferred timing. So you need to just inform that maybe walk when your pain is the lowest, or when you feel that the effect of your medication has taken place and you are good to walk for 30 minutes a day. So simple advices like this. Advice on wearing appropriate shoes while working out. To incorporate functional exercises is important. So for someone, say for someone who is a housewife, for them the most functional exercises can be, to move around in the house, maybe take a couple of stairs, and so that way you can just incorporate the functional exercises for someone whose daily activities involve certain kind of activities. And regarding aquatic exercises, water temperature should be between 28 to 31 degrees Celsius, which is recommended. So if you choose doing aquatic exercises for these population. Now, yes, so exercise prescription first, if you begin for someone who is very new to beginning with exercises, then initially it is going to have to take time for the beneficial effects to show. So a gradual increase in aerobic exercise duration by 5 to 10 minutes every 1 to 2 weeks over the first 4 to 6 weeks of an exercise training program is reasonable. And after the regular exercise for more than 1 month is done, the aerobic exercise fit principle is gradually adjusted upward over the next 4 to 8 months. So this is a very rough guideline, which gives us an idea that how much time frame it will take for beneficial effects to be seen in these people. And so once a level of exercise training the benefits has been achieved, it is recommended to have booster sessions after beneficial effects obviously has been achieved. So for example, that a muscle strength may be maintained by training muscle groups at least once a week and keeping the intensity constant. So initially when you are into the beneficial effects timeline, where you need to do 2 to 3 sessions of resistance training, and say that you have achieved certain goal, that you have achieved a manual muscle testing grade of say 4 or 4 plus, and which is sufficient for your patient, then you want to maintain that 4 or 4 plus grade for that individual. And so for that, at least once a week of the same intensity training is recommended after the set goals are achieved. Now here, it is very important to know the challenges which come these individuals. Now, whatever we have seen, the exercise prescription till now was pertaining just for the knee osteoarthritis patients. But as we have already seen, that these individuals are not going to come to the clinic alone with knee osteoarthritis. They are going to come with certain other, at least one or more of the comorbidities, right? So exercise prescription for people with multiple chronic conditions, it can be challenging because there are variations in the exercise doses which are recommended for individual chronic conditions. Say for example, obesity requires higher doses of exercise to reduce the weight than does arthritis or diabetes. Like you can see in this table that the intensity, the time required for exercising for obesity is 30 to 60 minutes per day. But at the same time, for arthritis, it is just 20 to 30 minutes per day, right? So that way there is a variation. You can also see that for type 2 diabetes, 3 to 7 days per week of exercises is required. But for arthritis, 3 to 5 days suffices. So if there is a comorbidity present, it becomes difficult to prescribe the exercises which would bring about positive changes in these individuals. So in such case, what you can do, first, it is very important to understand that, see, any amount of physical activity is going to help the patient, because we know there is a lot of evidence that supports the role of physical activity in reducing the risk of many chronic conditions and health conditions, right? So we know that there is a positive dose response relationship between physical activity and health. So any amount of physical activity should be encouraged in these individuals. Now, how to decide how to go about with these challenges is that you can begin with the FIT principle of exercise prescription for the single disease and health condition that confers the greatest risk. Now, say for example, you found that the disease itself is the greatest risk or the most limiting for the patient, okay, regarding their ADL, their quality of life, and or starting and maintaining an exercise program. Then for that, you can choose the most the FIT principle for the health condition which is creating most problem for the patient. Or alternatively, you can begin with the FIT principle that is most conservative. You can start with the lowest intensity and then gradually progress, and that progression is going to depend on the reassessment that you will be performing over a period of time. Okay. So as clinicians, the knowledge of magnitude and time course of response of the various health outcomes with the FIT principles that you use, it is crucial to assure safe progress and optimal outcomes for knee osteoarthritic patients. And it is also, as I already mentioned, it is also important to monitor the signs and symptoms very frequently. So you need to reassess in order to understand, in order to ensure that the exercise prescription that you are giving is safe, and they are having a proper adaptation and progression with the exercises. So till now we have understood the importance of exercise prescription and the challenges that we face, but all that is going to be a waste if we do not educate the patient correctly, appropriately. Okay, so it is really important to address the patient's concerns, their fears, and their beliefs in misconceptions, if there are any, which you will come to understand maybe in a few sessions from the initial consultation. You can understand what is bothering them, and you need to address those things. And you need to educate them about the condition, its prognosis, the need for the exercise prescription, or general fitness for their condition. And yes, also we need to educate them about the benefits of physical activity and exercise, and ensure that they adhere to the fitness program, right? So all of these is going to help tackle the situation of underloading the joint, which we have seen, which is the most common problem, which is hindering, the hindering in giving optimal outcomes for these patient populations. So overall, overall to summarize, we know that there is ample of evidence which supports that the physical activity or exercise is safest and most effective form of conservative management for individuals with NEOA, which is irrespective of the disease progression or symptom severity. Ideally, adequate exercise prescription, education, and self-management strategies should be offered to these individuals before considering any other form of treatment like pharmacological or surgical options. These latter options should be considered only when the prior one confers no further benefit or when all these options are exhausted. But these are ideal situations. We do not always face such ideal situations commonly in our clinic. So yeah, at least adequately prescribing exercises will give an optimal outcome, and it should be patient-centered and individualized so that at least we make sure that the patients are benefiting the most from this. So following this on the part of the clinician is a part of good clinical practice. These are the references. You can have a look at these and read most of the articles which are really helpful and have been updated. So that concludes this presentation. Thank you so much. I will stop the screen share here.
Thank you, ma'am. Thank you so much for your insight on exercise prescription for older adults with OAE. Ma'am, we understand that osteoarthritis in itself is a very common thing that any clinician or any physiotherapist for matter would come across. But there's always a thing that we would have prescribed a lot of exercises. Considering older adults, what do you think? How do we manage their home exercise program, as that is also one part of their education, that how they are supposed to be managing their exercise program, or how do we keep a track that they are not underloading or overloading their joints?
Right. So, so for a home exercise program, it is really important in the first place that we do a good physical examination. So in order to prescribe certain kind of, say for example, you need to do your knee extensions and flexions with a 2 kg weight. So most of the times what happens, we randomly just prescribe that resistance training, but it should not be the case. If we take some effort in order to find what optimal weight or resistance will give a beneficial effect in that patient's condition, then it will help us to make them understand that, see, if you do not do it with maybe 2 kg, we won't get the result. So, and as we have seen that the resistance training improves the pain, it improves the stiffness, so it improves the strength. We know those benefits, so we can tell the patient that, we are looking for these outcomes. So if you adhere to doing your exercises with such and such load, you are the one who is going to benefit the most.
Yes, that is, counseling is always going to be a very big part of actually implementing physiotherapy for that matter. Again, considering they are older adults and they have already been taking care of many other things, other issues in themselves, the comorbidities and everything.
Yes, so it is not always possible practically that, you begin the whole exercise prescription thing from the day one itself. Yes, it will take a few days of time to understand their situation and also to conduct all these evaluations. So in one day it may not be possible, but over a few days of session, you understand their belief system as well. You understand their physical presentation, and then you take a note of how you want to go ahead with the exercise prescription.
Even before, I guess, even before actually giving them a home exercise program, we call them for a few more sessions and monitor them, how they are actually carrying out all the exercises is always useful.
Yes.
Ma'am, there's always query that if weight bearing exercises in the recent days, the weight bearing exercises are given more importance, even with osteoarthritis. So, what do you think, according to you, in your clinical practice, how many actually do it properly? Because weight bearing is always going to be painful for them, and actually making them do a few exercises is going to be a little difficult as well.
Yeah. So that's a really good question here, and I hope that it is going to help many who are going to watch this. So see, most of the researchers have shown that any kind of exercise, whether be it weight bearing or non-weight bearing, are having positive outcomes on the individual's part. Okay, and this misconception that doing weight bearing exercises should be contraindicated is not, it is has to be addressed, because see, certain there is a variation of the osteoarthritis presentation that we see. Okay, so it is on the part of the presentation that you decide whether you want to give weight bearing exercises or you want to unload the patient. Okay, so if you see that someone who is able to manage their walking, in the history you will come to know, in the physical examination you will come to know that, say for example, their condition is getting better day by day, they are able to say walk 30 to 40 minutes every day, they are able to sit cross leg for 10-15 minutes. So someone who tells me that I'm able to do all these things, I would be happy to give them weight bearing exercises. But if someone is telling me that, I cannot walk for 5 minutes or 10 minutes and then the pain starts and it is so much that I have to sit down, or if I'm not able to cross my leg comfortably, I have to just, straighten my leg in a minute or two. So that shows the severity of the condition. And so based on that, I will decide that, yeah, maybe I can start with non-weight bearing first, and then later on, at a later stage after reassessment, I can again see to it whether I can introduce weight bearing exercises or not. And at the same time, I will also look into the matter if the patient has a belief that weight bearing exercises should not be done. So certain patients have a conception that the pain has started in the knee. So my relatives have said that, stop walking, stop using the stairs. And so because of all those things, they limit themselves so much that we know that it is going to increase the other risk factors. Okay, so you need to address that as well. And there are research which has shown that doing exercises like walking, which is aerobic exercise, is not going to progress the disease.
Considering again the severity of the osteoarthritis or the grade of the osteoarthritis,
yes, it does varies.
Yes, and maybe we can modify the exercises also, even to keep up with their physical fitness for that matter. Maybe we can shift to a few chair aerobic or sitting based aerobic exercises as well, although we want to promote weight bearing on the painful knee as well.
Right.
Ma'am, how do you think, again, considering an Indian scenario, very rarely patients are actually open to wear footwear even at home. So how would you actually counsel? Because we do come across people, patients with osteoarthritis, that we would want them to use some kind of, not necessarily an orthopedic footwear, but some kind of footwear that actually reduces the stress that is coming on their knee. So did you actually have to counsel a lot for someone to use such footwear?
Yes. So what happens, how I tackle this situation is that I ask them to, I don't tell them that you have to do this, but I ask them, just try for maybe 10 minutes a day or 15 minutes a day. Say, for example, it's a female who wants to stand for at least 30-40 minutes while cooking. So maybe you give them an option that you try wearing a footwear for 15 minutes and then try without the footwear, and you tell me how much result or how do you feel with that situation. So yes, it takes time to persuade the patient in following what you want them to do, but the ones who understand and the ones who appreciate the effects of wearing proper footwear will continue. But the ones who do not, after persuading a lot, who do not, you cannot do anything about it. But yes, you can have various ways of handling this situation and telling them what you can do in different methods. So I usually ask them to do it themselves, experience, and then decide for themselves.
What does them good and which is comfortable, more comfortable for them.
Yes.
Yes, I'm true. Again, the theme of this year's World Osteoarthritis Day itself is let's get physically active. So I guess this was very appropriate for us to actually have a talk on exercise prescription. Thank you, ma'am. Thank you for making yourself available for this webinar. See you again, hopefully with many other such topics. Thank you for being
Thank
with
you
us.
so much. Thank you so much for having. And it was a pleasure to deliver this presentation on this occasion.